We're moving on to Unit 13, Investigation of a Positive Direct Antiglobulin Test. Let's begin by talking about the clinical significance of a positive direct antiglobulin test. Just because the DAT is positive does not mean that the red cells will have a shortened survival time. Positive DATs without clinical problems occurs in about 1 to 1,000 to 1 in 14,000 blood donors and 1 to 15% of hospitalized patients. So again, they have a positive DAT, but it's causing no harm. IgG and C3d coating of red cells. Healthy individuals can have 5 to 90 molecules of IgG and 5 to 40 molecules of C3d coating the red cells. This is below the threshold of detection. And remember, in any laboratory test, we're looking at sensitivity and specificity. And in this case, the sensitivity, the ability to detect a clinically significant amount, it's not here. We have to have heavy coating, which is more likely to indicate clinical problems with the patient. The DAT can detect 100 to 500 IgG and 400 to 1100 C3d molecules. We're going to talk about the causes of a positive DAT, and several of these we've already discussed. Autoantibodies will be one of the primary focuses. Alloantibodies, for example, in a hemolytic transfusion reaction we talked about. Passively acquired alloantibodies from plasma or derivatives. For example, if you have a patient that has received Group O blood and they're Group A, then they will have passively acquired anti-A in their serum or plasma. Maternal alloantibodies, we've discussed this, hemolytic disease of the fetus and newborn. Non-specifically adsorbed proteins or membrane modification. This is the mechanism for some drug-induced hemolysis. And then drug-induced antibodies are also part of this discussion. Antibodies produced by passenger lymphocytes, we've talked about this. This is graft versus host disease. And complement activation due to a bacterial infection. Autoantibodies or alloantibodies. Many students get really confused about the difference between an autocontrol versus a DAT. An autocontrol is run as part of an antibody workup and is not the same as a DAT. So let's talk about the procedure. The autocontrol is treated like screen or panel cells. So you add serum and plasma and an enhancement reagent. There's an incubation period, and then you wash 3 times and add anti-human globulin. This autocontrol may be positive due to the testing procedure itself, because in this procedure it detects in vitro red cell sensitization. That's the principle of the autocontrol. It detects in the test tube red cell sensitization. If the autocontrol is positive, perform a DAT, and the DAT may be negative. And again, because the autocontrol is not the same as the DAT. And you say, well, at the end we washed 3 times and add Coombs. Yes, but you added an enhancement reagent, you incubated at 37 for whatever time, then you took it to Coombs. So it's not different. The same. Sorry. The DAT, the cells are taken directly to the anti-human globulin phase. So you take a wash drop of cells, you put it in a tube, wash 3 times, be sure and agitate in between every wash to break up the button at the bottom so you don't get a false negative, and then you wash 2 more times. There's no adding of serum or enhancement reagent, there's no incubation, and so the DAT detects in vivo sensitization. So I want you to be aware of the difference between an autocontrol and the purpose it serves, and the DAT and the purpose it serves. One is in vitro, one is in vivo detection. So you've done this enough that you know that there's 2 fragment antigen binding sites on the antiglobulin molecule that bind to the fragment crystalline portion of the sensitizing antibody or complement on 2 adjacent red cells. bridging the gap and causing visible agglutination. The strength of the agglutination is proportional to the amount of bound protein. So if you get a 4+, that means there's a lot of protein, either complement or IgG, bound to the cell membrane. If you get a 1+ or a weak 1+, that means the coating is minimal. So we've talked about what causes a positive DAT. Now we're going to talk about reasons for performing the DAT to screen for clinically unexpected autoimmune phenomena. So if a patient is having some autoimmune hemolytic anemia, the DAT in most cases will be positive. To detect the early manifestation of an immune response to recent transfusions, so the patient's actively making antibody to transfuse donor cells. When you do the DAT, you will get mixed field agglutination because the donor cells will be the only cells coated. So you'll have these small tight clumps. It's probably going to be a 1+ to 2+ type reaction in a sea of free cells, which are the patient's cells that are not coated with the antibody. And then the most common reason is to assist in the diagnosis of hemolytic disease of the. To verify in vivo sensitization, EDTA samples should be used, and I would like to say must be used. Now, if you're using clotted samples for your pre-transfusion testing, you can test a drop of the clotted sample and see if it's positive or negative. Because if it's negative, you're good to go. You don't have to redraw the patient for the EDTA sample. But if it is positive on the clotted sample, then you must get an EDTA sample, because there can be false positives due to using a clotted sample, which we'll talk about in a bit. The EDTA sample will also provide free red cells for elution if necessary. There have been times that I've had to smash a clot through a sieve because the patient was a very difficult stick or difficult draw in order to get the red cells needed for an elution. But again, by having this EDTA sample, it's anticoagulated, the cells are free in solution. That's the easiest sample to do an elution on. If a cold hemagglutinin is suspected, keep the sample at 37 degrees. So have the sample drawn, and when it gets to the blood bank, stick it in the heat block. This will prevent cold reacting antibodies to go on to the red cell. Let's talk about a few causes of false positive DATs. We want to detect in vivo, in the body, sensitization, not in vitro in the test tube. False positives are most often associated with using refrigerated or clotted samples. In the clotted sample, there can be coating, nonspecific coating of the cells with protein, and if you put it in the refrigerator, then there could be a false positive due to the red cells being clumped due to cold autoantibodies that are very, very strong. Any positive obtained on a clotted sample should be confirmed with the EDTA sample. And again, the EDTA will provide those red cells which are necessary. The most important part of working up a patient, whether you're doing pre-transfusion testing or you have problems, is the patient's history. First thing I do when I get a cross-match, I look that patient up to see if they have previously had an antibody and to verify what their type was before. So the patient history is crucial to the investigation of the positive DAT. So what you want to do is, some of these require calling the nurse and asking her to look this up in the chart. Is there a history of recent transfusions? Because this could be either a primary or an anamnestic response to transfused red cells. Administration of drugs previously associated with immune hemolysis. So we keep a PDR in the transfusion service, a physician desk reference, that lists all the medications, what they're used for, dosage, and what are the side effects. Because some drugs are well known, and it's rare, but they can cause immune hemolysis of the red cells through a variety of mechanisms, which we will talk about. Do they have a history of hematopoietic progenitor cell or organ transplantation? So again, the hematopoietic progenitor cells, if they're used for a bone marrow transplant, we can cross ABO lines. So let's say that you have a group A patient and we're replacing their bone marrow with group O. Well, once they engraft, they will start making their antibodies and the A cells that are remaining will be destroyed. In fact, this is a really good sign, those of you who may work in a transplant facility, because the decrease in group A cells and the increase in group O points to the success of the graft. And then organ transplantation, again, we could potentially get passenger lymphocytes that may make antibodies to the tissues, including red cells. Has there been administration of intravenous immunoglobulin, IVIG, or IV anti-D? And this is used to treat thrombotic thrombocytopenic purpura, also known as TTP. And most frequently, we have idiopathic TTP. So these two medications have been proven to be successful in terminating the TTP. Not always, but it is one of the treatment options. And because these are antibodies, we can get positive reactions. So any of these situations may lead to coating of cells in vivo. The serologic investigation of the DAT includes the following. You want to perform the DAT on red cells with both anti-IgG and anti-C3d to characterize the proteins coating the red cells. Now, sometimes me personally, I like to use polyspecific. It has both anti-IgG and anti-C3d. If that is negative, then I don't have to go any further. But if it's positive, then I have to pull out my monospecifics and test a drop of red cells with each one of them to determine is it IgG, C3d, or both that are coating the red cells. You want to test the serum or plasma to detect and identify clinically significant antibodies to red cell antigens, and you may have to distinguish autoantibodies from alloantibodies if they're present. And that's the most dangerous thing about strong autoantibodies, is that they may mask or cover up the alloantibody if it's present. For the DAT that's positive, you want to prepare and test an eluate from the DAT positive red cells to define whether coating protein has red cell antibody specificity. The eluate from complement-only coated cells should be tested if clinical evidence of hemolysis. Although if complement is coating the cells, there's really nothing that can be done. I mean, if you remove complement from the cells and test that eluate, because there was no antibody present, it should be negative. Concentrates the IgG antibodies that are coating the cells if present, which may not be present in the patient's serum or plasma. So as an autoimmune process starts, the antibody is going to go onto the antigen that caused its production. So initially, all the antibody will go on the patient cells if they're the target, or to the antigen positives if those are the target. And so as they're being produced, they're all going onto the red cells, so there may not be detectable antibody in the. So again, one of the important procedures to do for IgG-coated cells is an elution. And this removes the antibody from the sensitized red cells and recovers the antibody in a usable form. So we're going to pop the antibodies off the red cells, get them in a solution, and then test that solution just as we would serum or plasma. Many types of elution procedures are available, and no single method is ideal in all situations. And in our transfusion service, we had a book that listed a variety of different types of elution procedures. Thorough washing of the red cells is essential to ensure that antibody detected in the eluate is only red cell bound antibody. So let me give you an example. We had a patient with a really acute hemolytic anemia, autoimmune hemolytic anemia, and she was chronic. So there would be times that she would be on heavy-duty steroids to suppress that immune response, and then she'd go along, and all of a sudden she'd go into crisis where she massively produced this autoantibody. So we were real used to her because we've dealt with her for years. And so I washed her cells the traditional way, 20 drops 3 times, and you use a pipette to decant the solution. If you pour it in the sink, how many drops did I say we use? 20 drops. If you decant in the sink, you're going to lose half of your red cells or the majority of your red cells. So you carefully pipette off the supernatant. Now with the last wash, after the last wash, you pipette that into a tube labeled with the patient's name, number, and eluate. So I tested hers, and then you test the last wash control in conjunction with the eluate, side by side. The last wash control is your negative control and must be negative. Hers was 4+ with all 3 screen cells. And I said, okay. So I got a big 12 ml vacuum collection tube, plain red, and I put the 20 drops in there, 20 drops, and filled it with saline, washed it 3 times, and tested the last wash. It was 4+. And so it gets to a point whether it's just of academic importance. And so we went ahead and just tested the eluate just for grins. And of course it was 4+ all the way through. But this was an autoantibody with it's a non-specific. It's just against her red cells. And the diagnosis was there and we knew what we were dealing with. So again, the last wash, the purpose of the last wash will detect whether cells have been washed sufficiently and is the negative control for the test. If it's positive, and sometimes I would test my last wash first, because if it is positive, then your cells need to be washed more. Because once you add whatever it is to elute the antibody, you're done with those cells. You'll have to start over with a fresh 20 drops of cell. So here's a picture that's an example. So the elution techniques freeze the antibodies from the sensitized red cells so that the antibodies can be identified. So you see that the cells are coated with IgG. Then we perform an elution, and that pops off the antibodies. Because we're going to spin it down, the red cells will be at the bottom of the tube, and the eluate containing the antibodies will be in the supernatant. You take that supernatant and test it just as you would a serum or plasma to do an antibody identification against the panel. So once the antibody is freed from the red cell, test against the panel to identify. This is an example of an antibody removed from a patient's red cells that has specificity to the E antigen. And this could be either alloantibody, and the history is crucial, that the patient was recently transfused, and these are donor cells coated with patient antibody. Or if they've not been transfused, some patients who are developing a warm autoimmune hemolytic anemia, their antibody will initially have Rh specificity if you catch them in the progression of their disease. So this could be patient cells who are E positive, and they're making an autoantibody that initially has an anti-little e specificity. So you do the panel, it just looks just like an anti-little e. As the disease progresses, it becomes non-specific, this autoantibody, and will react with all cells tested. But again, this gives you an example of removing an alloantibody, and we pop it off the cells to where that antibody is free in solution, and we're able to further studies, or when do I stop? So no further testing is needed if the following 3 criteria are met. There are no unexpected antibodies present in the serum or plasma. Only autoantibody is detected in the eluate, and there's been no recent transfusions. If those 3 criteria are met, then you don't need to do anything else. Otherwise, if there is an immune antibody, confirm the specificity of an alloantibody if it's present. If the DAT is positive, but the serum or plasma and elution studies are negative, suspect drug-induced hemolysis. In that case, you're going to send the sample to a reference lab. If ABO incompatible components have been transfused, test for anti-A and anti-B. For example, with platelets, sometimes we don't have enough group A platelets, so we'll give group O platelets. And there's a tremendous volume of plasma on a platelet concentrate. So this could cause the patient's A cells to give a positive DAT. So in addition of running your panel cells with the eluate, you'll also want to throw in an A cell and B cell. This is why the patient's history is so important. If a patient is an infant, perform appropriate testing on a maternal sample and an elution on the cord cells. So this is a time, where is the antibody in the highest concentration? In the mom. She's the one that's making it. And then can we draw 3 mLs of blood from a newborn? No, absolutely not. That would be a cause of iatrogenic anemia. So again, we would use the cord cells. If it was a clotted sample, we have this pestle and mortar, not mortar, but it's a sieve that we squish the clot through, and we grind it up to release the cells. It's kind of gross, but it's kind of fun in a way. So what are some indications of immune hemolysis? Immune hemolysis means that it's causing, this antibody coating is causing shortened red cell survival due to some type of immune reaction. How is this diagnosed? Well, we have all our blood bank testing, and then we look in other departments. You must understand that you do not compartmentalize yourself. If you have a patient coming in with a 3-gram hemoglobin, you better be going over to the blood bank and say, I just want to warn you that this is what the patient's hemoglobin is, because they're going to be ordering a cross-matched DAT. So again, we want to look at chemistry results, we want to look at urinalysis results, we want to look at hematology results. This is your job. This would be a need-to-know laboratory results on a patient, even though you didn't perform the testing or it's not in your department. So have a decreased H&H. As the cells are destroyed, H&H falls. Increase in reticulocytes, because if the hemolysis is acute, you're going to start turning out red cells that are not quite ready. And which red cells are those? Your reticulocytes. So you'll see an increase. Lactate dehydrogenase in the cells is going to be released, going to cause a high value. Decreased haptoglobin. Haptoglobin is a protein that binds hemoglobin, and when there is hemolysis, the haptoglobin levels will go down. Bilirubin will increase because this haptoglobin is going to take the hemoglobin to the liver, where the liver breaks it down, because we're wonderful at recycling the materials inside the red cell. But if there's too much breakdown of hemoglobin, then the bilirubin is going to go up, and the patient may even be jaundiced. Hemoglobinemia, okay, that means when you spin the sample down, the supernatant serum or plasma will be red. Hemoglobinuria, that's blood in the urine. And again, your capacity for reabsorption of hemoglobin is minimal. Once it exceeds that threshold, you're going to start dumping hemoglobin into the... This is the end of Unit 13, Part 1.